Good afternoon, and thank you for asking me to talk about endoscopy in PTEN Harmatoma tumour syndrome, what you need to know. My name is Andy Latchford. I'm a gastroenterologist and assistant director for the polyposis registry at St Mark's Hospital. Today, I thought I would cover some various aspects of endoscopy in PHTS. The first is bowel polyps and other endoscopic findings. Address some of the data regarding the bowel cancer risk in this syndrome, current recommendations for colonoscopy, and finally some tips and tricks about how to optimize colonoscopy. So the first thing to say, I think, is that bowel polyps in PHTS are really, really common. And in fact, they're reported to be found in up to 95% of patients. But there is enormous variability, both in terms of the number of polyps. Some patients may have none, some may have hundreds or thousands of polyps. In addition, there's a significant variation at the age at which these polyps develop. Sometimes they can occur in childhood and indeed are the presenting symptom with which the diagnosis is eventually made. Others won't develop polyps until they're in their adult years. It's also really important to note that there are very many different types of polyps found within PHTS, which is quite different from most syndromes. And this sometimes is a clue as to an underlying diagnosis of this syndrome. I think it's also really important to note that most of the polyps found are not precancerous, but the key for colonoscopy is to find the precancerous polyps and target those for removal. Although we don't routinely recommend assessment of the stomach and the esophagus at endoscopy, we do know that polyps can be found in the stomach, and again, there can be a variety in terms of number and type of polyp. But there's no definite significant increased risk of cancer in these areas. Interestingly, there are some findings in the esophagus which are very characteristic of PTEN Harmatoma tumour syndrome and can give a clue to the underlying diagnosis. And it's shown in this picture here, where you can see lots of these little white flat lesions throughout the esophagus or gullet, which is a posh term called glycogenic acanthosis. And if these are found in a patient who also has multiple polyps in the large bowel, then it's almost diagnostic of this condition. In terms of addressing bowel cancer risk, this is really difficult. We have to acknowledge that PHTS is a rare condition, and therefore the data on which we base risks is often skewed in rare conditions and are often lower than the medical literature would suggest. And the reason for this is because the diagnosis is more likely to be made in patients who have developed cancer than those who have little or no symptoms, and therefore these groups never have a diagnosis made. I think there's enormous variability within individuals who have PHTS, and again, this causes difficulties. And so it's difficult really to give precise risks. I think the risk is debated, but I don't think bowel cancer risk is a major issue in patients with PHTS. The lifetime risk is reported to be in the order of approximately 10%, but there's very significant variation within the studies that have been reported. And I think we need to be mindful that the background general population risk is probably in the order of 6%. So it's not dramatically higher than the general population. On average, in the studies, when bowel cancer does arise, it seems to arise in the 40s and 50s, and therefore it's not a cancer that arises at a young age. And this puts it mostly into the area where it's often covered by the National Bowel Cancer Screening Programme. So what are the recommendations? Well, colonoscopy is recommended, and it's performed with the intent to find precancerous polyps and to prevent those polyps developing into cancer. Also, colonoscopy can be beneficial in that it can detect cancer at an earlier stage and therefore opens up different opportunities for treatment and is associated with a better prognosis. Unfortunately, because of the rarity of the condition, there is massive variation in the guidelines that have been published. And indeed, these variation and different recommendations persist. There's lack of consensus, particularly between guidelines that are produced in America and currently produced in Europe. And this here, if those who are interested in the most recent European guidelines, this is the reference, which is formed by a group of experts across Europe as well as the UK. And these are the guidelines that we would use certainly locally within London, but also being adopted on a national basis. And these guidelines would recommend that a baseline colonoscopy is performed at the age of 35 to 40 to look at the total polyp burden. However, if that baseline colonoscopy is normal, then individuals should not need any increased screening above the general population, i.e. further colonoscopy would not be required, but they would be invited to enroll in the National Bowel Cancer Screening Programme and follow those screening programme recommendations. What these guidelines don't cover is what happens if polyps are found. And certainly if polyps are found, then how often colonoscopy is required is usually personalised according to an individual's needs. We don't have a fixed surveillance interval for patients with PHTS. We amend it according to an individual's number of polyps, type of polyp, etc., etc. The other important thing which wasn't addressed in these guidelines, that irrespective of when you should be recalled for colonoscopy, if you have bowel symptoms, then you need to talk to your medical team about this, because colonoscopy may well need to be brought forward. If this means that you had developed bowel polyps at younger age than 35, they should be reported. If you have had a colonoscopy and you develop new bowel symptoms, then again go back, because it may well be that the surveillance interval that was planned would be shortened. So finally, tips and tricks to optimize colonoscopy. And here I'll cover issues regarding bowel preparation, sedation, and then finally the endoscopist himself. So one of the key things for colonoscopy is to have good bowel prep. And here I've given you representation of what bad and good bowel prep looks like. Bad bowel prep is like snorkeling in the North Sea after a storm, and the visibility is atrocious. However, good bowel prep is like snorkeling in the Maldives in the glorious sunshine, and you can see tiny fish many, many meters away. And when the aim of the colonoscopy is to detect precancerous polyps with a view to removing them, it is clear that good preparation is mandatory. So what can you do to achieve that? So the first thing is follow the dietary instructions. When you have information sent out, there will be a list of foods to look to avoid. And in particular, foods that are low fiber should be pursued, and you should avoid things with seeds and pips. Seeds, pips, and fiber are the endoscopist's nightmare, because we cannot suction them out of the bowel and they keep clogging up the scope. The second tip is keep your fluid intake high, and I would say at least 2 litres of water a day for 3 days, provided there's no medical reason why you shouldn't be able to drink this volume of water. Not only will it help purge the bowel and improve the bowel prep, but it stops you from becoming dehydrated and feeling unwell as a result of the laxative effect from the bowel preparation. I think it's fair to say that none of the bowel preparations are nice, and I think we all acknowledge that as endoscopists, but there are a number of options that are open to you. Now, some of these, however, may be limited depending on your blood test results and whether they're available. But there will be some flavours that you don't like, in which case other options are available. It may be that you find high volume bowel preparation really difficult to cope with, and there are low volume bowel preps that may be open to you. So there isn't a one bowel prep. We can modify this according to your personal tastes and needs. But I think if in doubt, ask. If you've not had a colonoscopy before, many of you may be offered an appointment with a pre-assessment team where you'll have the opportunity to ask about things like dietary restriction and options for bowel preparation, and they're a great resource for information. Also ask your medical team at the time that you discuss the procedure what it entails, the risks and benefits. You can ask them about medication, about bowel preparation and different options that are available to you. So what about sedation? So I apologise for the slightly ironic cartoon, but colonoscopy, contrary to popular belief, does not need to be painful. There are all sorts of options that are open to you. Some people choose to have nothing whatsoever and have a colonoscopy with some bloating and wind discomfort, but nothing more than that, and that's absolutely fine. Some people use Entonox, which is an inhaled gas, which has a fantastic quality for pain relief. It's also known as laughing gas and gas and air. It's also commonly known as the painkiller that is often used in pregnancy. This can be used on its own, but can also be used in addition to standard sedation. When we talk about sedation, we generally refer to a strong painkiller as well as a drug that has a sedative effect. And the doses of these can be varied, and indeed additional doses given during the procedure. So I often liken this to a bottle of gin, that we may start off with a couple of double gin and tonics, but if we need to, we can go up towards half a bottle of gin or indeed a full bottle of gin. And and at those higher doses, also, if you also had a bottle of gin, you may not remember too much about the procedure. Similar sorts of effects can occur with the high levels of sedation. But the level of sedation, again, should be personalized according to you, your particular need, your experience of the procedure, but also will take into account your age and whether you have any other comorbidity or other health issues. And final option would be propofol or a general anesthetic. Now, of course, this is the most extreme and is usually reserved for those who've had failed procedures with sedation. And part of that is because of the poor availability of these lists in general. So for sedation, it is different for everybody. So there isn't a right or a wrong answer. It needs to be tailored to you and your particular individual circumstances and wishes. I would absolutely recommend talking to your endoscopist, the endoscopy nursing staff and the pre-assessment team. Just explain what your concerns are, what your wishes are, and they will then be able to adapt things accordingly. But important things to take, which will need to be taken into account, is have you got an escort? If you don't have somebody who can take you home and can stay at home with you for the rest of the day, then you won't be able to have sedation or an anaesthetic. Do you need to drive? Again, if the answer to that is yes, then again, you won't be able to have a general anaesthetic and you won't be able to have the sedation. For those things, you're not supposed to drive for 24 hours. Finally, moving on to the endoscopist. For me, as an endoscopist, I think this is absolutely crucial and really important. My personal opinion is I think this is really specialist work and should only be done in centres where they're used to assessing patients with PHTS. So my advice would be is when you're offered colonoscopy by the medical team, ask them if they have experience of this condition. And if the answer is no, then I think there's absolutely nothing wrong in asking to be referred to a specialist unit where they are, because some of the findings in this are quite alarming potentially to some endoscopists who've never seen the case before. And it's the interpretation of the findings and knowing how to action those findings that is most important. And a lot of that comes with the experience and an understanding of this extremely rare condition. So in summary, for those with PTEN Harmatoma tumour syndrome, bowel polyps are common. The bowel cancer risk is raised a little, but probably not as high as the medical literature has reported historically. Currently, colonoscopy is advised at age 35 to 40, and thereafter, your care should be tailored according to your individual need. And my recommendation is that these procedures should be done in specialist centres by endoscopists with an experience in PHTS. I hope you found that helpful, and I'm sorry that I haven't been able to be with you on this day. Thank you.